Good morning, everybody, and welcome. And we're glad to see everybody turn out on this cold Tuesday morning for an exciting topic, looking at changes coming in reimbursement. Before we get started, just a couple of housekeeping things. If you need CPE credit, please fill out the form. We can't give you credit without the form filled out. Also, please give us your feedback. We look forward to getting your thoughts. And when you give us your feedback, we're going to be continuing with our healthcare helpings throughout 2019. So if there are topics that you would like to see presented, please feel free to write those in on the form. That would be very helpful. So without further ado, one more housekeeping thing. I know most of you will want to ask questions during the presentation, and I think the speakers, both of them, are okay with that. What I would ask is raise your hand and wait for me to get to you with the mic, because we are recording this session this morning. So our two speakers this morning, our first speaker is Stacy Sternberg. Stacy has multiple initials after her name. I think it's on the next slide, Stacy, which I won't read, lots of initials. She's a coding and compliance consultant with KraftCPAs. You see all the initials now. Stacy has a wealth of experience in coding and reimbursement for, especially for physician practices and revenue cycle consulting. Jessica Benson is a CPA and manager in our healthcare industry group at Kraft, and she's going to be speaking on some changes with MIPS coming up for 2019. So without further ado, Stacy.
Good morning. Okay, wait a minute. I got to figure out how to use the little clicker things. I'm going the wrong way, or something's not working. There, it's moving on here, but not moving on there. Okay. First thing I'm going to talk about is physician fee schedule final rule. And this is, guys, anything I say today, I'm going to throw a disclaimer out from the beginning. First of all, this is not the final rule in its entirety. The Cpt codes that I'm going to talk about, use your CPT book, use your ICD-10. Those are your guidelines. What I'm going to talk about are some highlights and some high points. But always, 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 those are the things that you use, not what somebody says, not what somebody reads. You use those things as your main tools. These are guidance. These are tips and tools and things that you can take away from, that you can apply to your practice. But always use those as your reference, as your guide. There were a lot of things in the physician fee schedule final rules. These are some highlights. And the first two, the virtual check-ins and the RHCs and the FQHCs regulations to allow virtual check-ins, those were both added in 2019. And we're going to talk a little bit more about those in a few minutes. Those were proposed and they did get added. As most of you know, for E&M, there were supposed to be some big changes. That was postponed until 2021, so I'm not even going to get into those. That's a whole different session and a whole different ball game. But they were going to bundle some things together, and that would have changed a whole payment system and a lot of nice things, but that's been postponed until 2021. Providers are no longer required to prove patients are homebound and can't come to the office for a visit. Documentation of medical necessity required regardless of site of service. Documentation of medical necessity, that's a driving force of all documentation, irregardless. But used to, when there was a home visit or things like that, you had to say why. The physician, the qualified health practitioner, they had to say why. You know, the patient couldn't come to the office. They don't have to do that anymore. The whole thing is, why is the visit medically necessary? Again, that's the driving force of any documentation. You got to be compliant. Why did you go see them, and why was it medically necessary for you to be there? was a big concern for a lot of physicians. There was a lot of articles, there was a lot of topics on it. 50% reduction in E&M payment the same day as an office procedure. I'll pick on Ashley because I see her bright smiling face back there. But let's say she's got a new patient that comes in. Doc's never seen them. Comes in and they say, you know, I got shoulder pain. I don't know what to do. They do an office visit and they decide, well, you know what? We're going to do an injection today. We're going to see if that helps. They'd never seen this patient, so they didn't know up front that they were going to do this injection. They did a full-scale office visit, and a decision was made at that point, after the office visit, was complete, that they were going to do an injection. So what this would have done was they would have gotten paid half of that office visit. They would have lost half that revenue as a result of doing that injection on the same day. This didn't get added, so which is a big deal. And I keep clicking the wrong way. Physicians in the same group practice and same specialty would be allowed to bill multiple E&Ms the same day. This would recognize that physicians have different areas of expertise, even though they have the same specialty designation. Again, you know, a lot of you guys are in multi-specialty practices. You have the same NPIs. You bill under group NPIs. You know, this would give some, depending on how your contracts are loaded, sometimes they pay attention to a taxonomy code, sometimes they don't. This would have given recognition to, well, let's say Dr. Smith knows about hips and Dr. Jones knows about shoulders. You know what I mean? This would have said that, you know, they both could have seen the patient and both had a legitimate reason to do so. Bottom line, they didn't make a decision on this. This was paid. I wanted to bring this up, and I don't want to really go into a lot of discussion about this. This would be something you talk to your practice administrator about or whoever does your financials, but I did wanted to make you aware of it. Because when people look at the conversion factor and they see it went up by 5 cents, they're thinking, oh, I'm going to get some more money this year. Well, actually, you may or may not. Because what happened is the practice expense, the RVUs, the practice expense is like your rent. The things that go into that is rent, telephone, all of that kind of stuff. They're saying, okay, they're conducting an analysis of 2,000 items starting in 2019 that's going to result in price changes. And so what they're going to do is they're going to look at these, and those RVUs for that part of that code may or may not change, and based on that analysis. And so when they do that analysis, if those RVUs go down, you're not going to get that 5-cent change. So therefore, you're not going to see any kind of increase. You actually may see a decrease, or it may stay flat, or you may get it, you know. So just be aware of that. Don't count on seeing that. This just lets you know there were 335 overall Cpt Code changes. This breaks it down by section. E&M, surgery, radiology, lab had a ton. Proprietary, those PLA codes, you know, there's probably not a lot of people in here that affects, but the biggest are, so if you do in-house labs, I'd pay attention to those. Surgery codes. We did a AAPC meeting the other night, and we were talking a lot about this. A lot of the surgery codes now include the guidance. It was bundled in. You know, where it used to say with or without guidance, now it's more specific. Your skin biopsies, your fine needle aspirations, all that kind of stuff, they're very specific. So for those of you that have those specialties, utilize those codes, pay really close attention because that's going to impact your bottom line. And I'm going to pick on Kathy. She was talking about from Heritage. She had a code. She's going to lose $69 a code as a result of this. So I would encourage you to, again, look at these codes that affect your specialty, affect your practice, and pay close attention, because it is going to drive your reimbursement and your revenue. Patients over paperwork. How many people in here have ever heard of this initiative? Wow. In September, it started in 2017, but in 2018, CMS announced the proposed rule to relieve healthcare providers by removing unnecessary, obsolete, or excessively burdensome Medicare compliance requirements. Supposedly, the updates are going to save $1.12 billion annually, and they say if you take what they implemented in 2017 and 2018, as well as the other proposed rules, the estimated savings are going to be $5.2 billion. We'll see. I'm not going to put my dog in that race. I'm just going to tell you that it's there. All right. Included in this, I'm going to go over some of this stuff, but before I do, I am going to tell you that before I changed anything on my documentation, I would make sure that it is compliant and it is following guidelines, because there's a symposium. This year's was, I don't know if it's in Chicago every year, but I know it was held in Chicago this year. It's the AMA, the American Medical Association, is the one that drives CPT coding, and there's a symposium every year. And they take questions and they talk about it and they decide, you know, and there's always CMS representatives. Some of these changes that we're talking about, like this one, for established patient office and outpatient visits, when relevant information is already contained in the medical record, practitioners may choose to focus their documentation on what's changed since the last visit. And then it goes on further to say, on pertinent items that have not changed and need not record the defined list of required elements. If there is information that the practitioner reviewed, the previous information, blah, 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 blah. Okay. Now, and it also says that you have to clarify for E&M and outpatient visits, new and established, they don't need to re-enter medical record information on the patient's chief complaint, history. The practitioner may simply indicate in the medical record that he or she has verified this information. But here's where it gets interesting. See, at this symposium that I was talking about in November, CMS representatives were asked the following question. What is the defined list of required elements? What's the appropriate way for providers to show that they have reviewed and verified previous recorded data? They couldn't answer the question. They said it was okay for you to do this, but they couldn't tell you how to do it. So if you change your policy, if you change your procedure, and you do what they're saying it's okay for you to do, you don't know that you're being compliant. They're saying, both CMS and all that they would say was, look for more information from CMS and your local MAC. So again, from a compliance standpoint, from a coding standpoint, from a documentation standpoint, I wouldn't recommend you change anything until this additional information comes. Because if they can't give you that defined list of required elements, then how do you know what you're doing, what you're changing is okay? You're sort of in a catch-22. The next section I'm going to talk about are some Cpt codes, and depending on your specialty, these are things you may already be doing. These may be things that your practice is already doing that you can get that's basically found revenue. Yes, are you going to have to write a policy for it? Yes, are you going to have to fine-tune it? Yes, is it a provider education thing? But as a result, it'll help with your reimbursement. Interprofessional consultation. there were codes added, 99446, 447, 448, and 449. They're time-based codes, and they are telephone internet assessment management services provided by a consultative physician, including a verbal and written report to the patient's treating and requesting physician. Physician. Bottom line, in plain English, what it means is, let's say I go see my internal medicine person. He's like, oh, you may or may not have rheumatoid arthritis. Not real sure. I need help on this. So he calls a specialist, and he says, okay. He calls the rheumatoid guy, and he talks to him over the phone verbally. The rheumatoid guy sends an email. He says, okay. He spends, 5-10 minutes, and they talk. Rheumatoid guy doesn't see me. But now, there's some prerequisites to this. First of all, my treating physician has to ask my permission to do this because I'm going to get a bill. Legally, CMS cannot pay for anything 100% that's not a preventative service. So this is an 80-20. So the patient is going to get a bill, and you don't want surprises. So it is a patient education thing, but it's no more than anything else. And it can't be a blanket consent either. It's got to be for that date of service, and it can't result in me going to see that rheumatologist either. So these are all time-based codes. And then the 99452, that's the only one that the treating and requesting physician can bill. The other codes can be billed. There's several for the consulting, the physician that was consulted that they can use, but there's only one that the referring physician can use. And again, this is a provider education. I think about PEDS, and I used this example the other night. Most of you who know me know I have an autistic son, high functioning, but when he was about 8 years old, he had a medical issue, an endocrine issue. And his pediatrician was like, hadn't seen this, don't know what to do. So she consulted a guy at CHOP Hospital in Philadelphia. Called him up, talked to him. My son had, at 7 or 8, had the bone age of a 12-year-old. She's like, it's pretty new. What do we do this? Blah, blah, blah. So they talk on the phone. I knew what was going on. So had this been in place, she could have charged for that visit, for that telephone time, and he could have charged one of those other times because there was communication, there was dialogue. All they would have had to do is document that they spoke, how long they spoke, that kind of thing. And it's not a book. You can look these up. You can see the documentation requirements. I've got a slide in here. Yeah, see, 99446 through 449 and 451 are by the consulting physician. 452 is the requesting. We talked about this. It's 80-20. Treating physician must document patient consent. This is not a blanket consent and must be done each time. Each time. No blanket, not like when the patient comes in and signs their financial policy at the beginning, but every time they do this. This type of services is reported, includes both a verbal and written report. Verbal report can be done via telephone, email messaging. I mean, you think about, you got patient portals. Through an EHR, you've got 10 ways from Sunday to be able to do this. It's just a matter of getting it on paper, writing a policy, and being consistent on how you do it and make sure that you keep that documentation record. It can be used for new and established patients. It is not for the purpose of transferring care. It's not when you're saying, okay, go see this person, he's now going to take over your care. Can't be related to a visit 14 days prior, 14 days after. the entirety of the service should be billed with one code. For example, if time was spent over the course of 2 days, then one code would be billed with a total amount of time. So if Dr. Smith talks to Dr. Jones 10 minutes one day and 20 minutes the other day, you're going to bill it one time with 30 minutes. Now, again, I tried to find, and I'm opening up a whole can of worms, but I'm going to just be real honest with you. I tried to find some documentation about the date of service. Because if you talk 10 minutes on one day and 20 minutes on the other, and you're only supposed to bill it all together, what date of service you used. I couldn't find clear documentation on that. So I sent an email to AMA, and I don't have a response. So that's all I can tell you. I know that question's going to come, so I'm just throwing that out there. I did send a question, and I have not gotten a response on that, because I'm like, okay, it's sort of like the old radiology thing. Well, the radiologist read the X-ray on this day, but he didn't dictate, the report didn't get signed, but on this day, you know, it's a whole nother can of worms.
You have to check with the commercial side to see whether they cover these codes as well. I mean, Medicare.
Yeah, typically I would say I would check with my carrier-specific guidelines, but my guess is they are going to cover a lot of these codes because, as you and I both know, a lot of these commercial carriers follow, you know, CMS guidelines, and supposedly this is going to save. The thought process behind this is going to save money. The whole idea is if they can do this over telephone, this is going to save an office visit. So this is the thought process behind this is if they do this over the telephone, I'm going to pay them less than I would if they'd have to go to the office to get this information and see this specialist. And this is Palmetto. I went on there. This is the fee schedule. So if you look for participating, unless you're in concierge medicine, everybody's participating. So if you look, you know, the 452, the treating physician, he's right at $36. But if you look at the 449, that's $70. And you think about again, I go back to rheumatoid, arthritis, infectious disease, orthopedics, you know, some of these specialists, you know, and even if you're the one requesting it, that's $36. $36 you didn't have before. And it's a matter of education. Educate your physicians. And a lot of times when you talk to the physicians, if you show them the money that they can gain from it, and what the requirements are, they're really open to hearing that. All you got to do is, you know, show them what they got to do and show them what the revenue and the reimbursement that they can get from it. Okay. This is not the same as telehealth. It doesn't have the same requirements. It's a component, but it's not the same. And I always, this virtual check-in, this makes me think of all the many times I go back to when I had babies and pediatricians, because my pediatricians would have racked up. Let me tell you. Virtual check-in is defined as a brief communication technology-based service where a physician or other qualified healthcare professional who can report E&M services provided to an established patient not originating from a related E&M service provided within 7 days. Bottom line is you couldn't have seen them within 7 days, and if you're not going to have an appointment in the next 24 hours. All right, the first one, you see right here, how many of you have had a kid that's had roseola? First time you see them, they get this rash all over them, like, what the heck is that? And you freak out because you had never... I did. And you take a picture and you send it and you're like, what is this? Okay, they can bill that now. You know, you send in a picture, you can send it to the patient portal. You can send it, you know, and the nurse can call you back, and they can say, okay, nothing to worry about, Mom. You don't have to come in. Kid's not going to die. They're going to live. You're going to live. All's going to be well. Or, here we go on this one. You call them. We got projectile vomiting or something. I don't know. You call them and you say, okay, my kid's doing this, this, and this. Or they got an ear infection, something like that. You call them. Oh, well, you know what? I think a chronic ear infection. This has happened before. The doctor knows what's going on. Okay, it's time for whatever antibiotics. They're not better in 3 days. Bring the kid in. These are all, again, all of this is driven because it's supposed to, the thought process is they're going to pay providers now, because the thought process is this is part of that patients over paperwork. It's supposed to save money. It's supposed to prevent visits that can be done via telephone, via patient portal, that kind of thing. Sure.
Can these services be done by a mid-level or a tech?
Any qualified healthcare professional. They cannot be done by a tech, but they can be done by a mid-level, a nurse practitioner, an advanced practice nurse, a PA, that kind of thing. But the key to that is, you know, that qualified healthcare professional. Established patients only. CMS defines established patient as one who has received professional service. You hadn't seen them in 3 years. And again, this is the exact same specialty. That 3 years is for the exact same specialty and subspecialty who belongs to the same group or practice within that 3 years. Physicians must document the patient's consent. Again, not a blanket consent. You got to get it for each time this type of service is done. Virtual check-ins. This answers your question, Jack. Virtual check-ins can only be delivered by those practitioners authorized to furnish E&M services. Only physicians and qualified healthcare professionals are allowed to bill for these services. So that answers your question you were asking.
So we have techs in our ophthalmology practice, and some of them have professional certifications. One's a COMT or a COA, so they are actually certified. They wouldn't be considered a mid-level where they're...
Can they bill E&M services?
No, they're not licensed by the state the same way a mid-level would, but they have a formal certification.
I would say no. If their scope of service does not allow, and you'd have to look at the state of Tennessee, but it would be defined by their scope of service as what their licensing allows them to do in the state of Tennessee. So if they just have a certification and they cannot furnish E&M services, then they can't bill for it. There's no frequency. You can bill it 10 times, you can bill it 1 time. But if you bill it 10 times, then you better have 10 authorizations. No specific documentation requirements. Documentation for virtual check-ins is consistent with the requirements for other Medicare-covered physicians. Again, the only thing I'm going to say about this is don't write a book, but make sure your document tells the story. Your documentation tells the story of why you talked to them, what the medical necessity was, and what you told them to do. You know, why did you take that phone call? If I, as an auditor, am looking at that, you know, it wasn't just a social call. Hey, how you doing, Miss Smith? Haven't talked to you. How's your kids? School going okay? You know, no, so-and-so had a rash. They've had it for 3 days. It's new. You know, I told them that it was no problem, no medications needed. If it didn't get any better, come see me in a week or whatever the case may be. But make sure that documentation is clear, it is concise, and it tells the story of what that phone call was. And this is that, and these are those first two bullet points on that slide of the proposed rule. Rural health clinics and federally FQHCs can be paid for these services. You know, FQHCs are paid, they're paid a per diem rate. They can be paid for these services outside of that per diem using this code. Same with RHCs. And again, here's your fee schedule.
So those are Medicare codes, or their Cpt codes that are
Which code?
the
G
G code.
Again, no, they're HICS picks that were added this year. So I would check with my payers, because if Medicare's paying them, I can bet you, hadn't checked with Blue Cross, hadn't checked with Aetna, Cigna, but I would check with my payers, because, again, most payers, from what I'm seeing and what I'm being told and reading, you guys are on the front line, but from what I'm being told, payers are wanting to do this because they feel like it's going to save them money in the long run. They'd much rather pay you, $12 or $13, $14 than they had 20-something for an office visit or 30-something for an office visit. They're looking at this as a savings. So from my understanding, most payers, but again, don't take my word for it, check with them. Last but not least, for my part of the program, is the new Medicare Beneficiary IDs, or Identifiers, MBIs. Come take me, I'm old school. Pick numbers, telling my age. Medicare Beneficiary Identifiers. The law requires CMS to remove Social Security numbers from all Medicare cards by April 2019. So we are January 2019. So folks, it's coming. It's here. I would hope that whoever your vendor is, your software vendor, all of this has been taken care of. All your payers, accept, reject reports, should be your friend. You should know them. You should look at them. You should pay very close attention, see if this is an issue or a non-issue. A new unique Medicare number will replace the current HIC numbers on new Medicare cards. They started mailing them out in April 2018, and they meet, again, they got to have them out by April 2019. Patients who were new to the Medicare program as of April 2018 and later, they were all given the new MBIs. Practice management systems and business processes needed to be ready to accept the new Medicare, the MBI numbers, by April 2018. I'm thinking this is old information for y'all, but I wanted to stress it because April 19 is here. So I just thought it was worth a mention. This should be a non-issue at this point, but just thought it. The transition period when you can use either the HIC or the MBI exchange data. It started April 1st, 2018, and it runs through December 31, 2019. I would by no means wait and keep using HIC numbers through December, because if you do and you got issues, you're going to be in a world of hurt next year. Take care of it now. Don't wait. Even though that's the drop dead, just say no. Medicare Advantage plans have their own card through whoever that payer is. They don't, like Blue Cross or whatever, they'll have a number through Blue Cross. But now I will say, and I don't know, maybe y'all can answer this, are y'all seeing, this is the time of year where you'll start seeing those coordination of benefits things. So one of the problems you might run into is if, let's say, Ms. Smith got her new MBI and she has not given that information to her Medicare Advantage plan, and there's some issues there. So, I go back to accept, reject reports, especially this time of year. They are your friends. We all hate them. They all stink. Nobody wants to do it, but you better. Because otherwise you're going to lose a lot of money, and you're going to lose it quick. This is just an example of what they look like. You remember the old railroad cards? We could always tell those, and again, I'm dating myself, because they had the letter in front of them. And it really stinks that they don't anymore. I'm like, well, shucks. You got to pay attention. It says it out there now. I can't just look at the number anymore and go, oh, that's railroad. I actually got to look at the card. And for those of you that know me, that might be a little challenging. All right. There is a link that you can look at, and I'm going to turn this over to Jessica. But I do know that this presentation will be posted on Kraft's website. So for any of you guys that want to go back, look at it, and you can get those resources off there, it'll be out there for you to look at. It's all yours.
Well, good morning. Thank you, Stacy, for that wonderful information. So I'm kind of here to talk to you. Well, I'm not kind of here. I'm here in full person. I'm here to talk to you guys about the Quality Payment Program. This is like a lot of things we're kind of going over. It's old hat to a lot of people because it's been around for a couple of years. And truth be told, there's a lot of changes happening this year that are trying to really achieve what the Quality Payment Program had started out to do in the beginning, and that is to really figure out how to match up reimbursement to value-based care versus just a fee-for-service. So the Quality Payment Program started in 2015 from the Medicare Access and CHIP Reauthorization Act, obviously also known as MACRA. And as I said before, it's a transition of the fee-for-service to a value-based reimbursement system. A couple of things just that didn't really have a place in the rest of the slides I just wanted to touch base on. So there's submission methods to several of the categories. There used to be a criteria that you could only submit via one submission method. So they have edited the 2019 performance year submissions to allow for multiple submission methods. That being said, what they will do is they will take your highest achievable score across all methods, and you will then get credit for your highest score. There's been a lot of talk about an all-payer combination option. So that is so this is kind of based on Medicare and Medicare reimbursement specifically. But under the ACO pathway, they've been talking about creating an all-payer combination which combines not only Medicare but also commercial payers as well. So keep an eye out for that as we go along. Okay. So who has received a MIPS score and knows what it is? Anybody? Has received their MIPS score, knows what it is. Okay, awesome. So just a little bit about MIPS as a whole. So we know it's a payment neutral system. So in 2021 payment year, which is reflected in the 2019 performance year, they're assuming that about $780 million is going to be shuffled around among payers. That's 390 on the plus side and 390 on the negative side. In addition to that, there's a bucket of money. There's a $500 million bucket for exceptional performers. An exceptional performer is someone who receives 70 points or more in their final scoring. the thing about that is CMS estimates that 91.2% of the MIPS eligible clinicians will either receive a neutral or a positive reimbursement. So what that means to you is that you want to get the highest score possible, because that dilutes the ability for you to get that positive reimbursement adjustment. Okay. So I'm not sure if a lot of you know, but participation changes. So in 2019, they have added eligible clinicians. They are physical therapists, occupational therapists, speech language pathologists, audiologists, clinical psychologists, and registered nurse dietitians and nutrition professionals. These were not included in the 2018 and 17 eligible providers under the MIPS criteria, and they are this year. So if you have those on your roster, you want to make sure that they're following those guidelines and they are registered. There we go. I know this makes a lot of people happy that don't really deal with a lot of Medicare patients. The low volume threshold for 2019 participation has changed, and they've also added an additional criteria. So there were only two in 2018 and 2017, and it's based on your Part B charges, your people you see. So the low volume threshold period, there's two for you to determine it. It's 10/1/17 to 9/30/18 or 10/1/18 to 9/30/19. So those are the periods in which that Medicare can determine your low volume. The specific low volume criteria is 90,000 or less in Part B allowed charges, UC 200 or fewer Medicare beneficiaries, or you have 200 or fewer covered professional services paid under the Medicare fee schedule. So I don't know how many people are gluttons for punishment, like accountants during tax season, but you can opt into MIPS. So there's a couple of ways to opt in. If you are excluded based on this low volume threshold, but you say, hey, I know that I've got the ability to meet these criteria, I can possibly get a positive adjustment, I know my stuff. You can voluntarily opt in to participate in MIPS. Now, if you voluntarily participate, you have to do it before the payment or before the performance year starts, so you would have had to do it already. But once you do that, you cannot change your mind that year. So you can't get through June and say, oh, well, I don't really have all this stuff. I don't want to put all the documentation together. Stuff. You're stuck now. And when you opt in, you are then subjected to the positive, negative, neutral payment adjustment criteria, as is everyone who's a fully eligible participant. There is another way that you can participate, and that's kind of a report only. So you submit your data, but you are not then eligible for a positive, negative, or neutral adjustment. There's no change. You're just reporting data to say, hey, here's where we're at. Just so a little recap of scoring. There are four categories. Like I said, you've got quality, cost, promoting interoperability, which used to be the advancing care information, so the ACI is now called promoting interoperability because they love the extra words here, and then improvement activities. So just the performance period that are required to be reported under each quality, you have to have a full 12 months of data. So you remember when we first started, it was like, oh, you can do 90 days. The second year, you can go a partial transition. Well, this year, you have to report the full 12 months. That full 12 months of data equals 45% of your total score. Cost, again, is a full 12-month reporting period. However, you don't have to do anything. All this stuff is gathered by Medicare based on the per capita cost as well as your spending per Medicare beneficiary within your practice. That's all numbers run by Medicare themselves, so no requirement on your part. Promoting interoperability has to do with your certified healthcare, CEHRT, so certified electronic healthcare record system. And that is a 90-day period. It makes up 25% of your score. People who meet exclusion criteria, people who have a certified healthcare system that got decertified by the Medicare system, they can apply for an exclusion. People who are in rural areas who have limited or no access to internet, to be able to have that interoperability with reporting, can apply for the exclusion, and then that 25% of their score gets reallocated to quality. So now you're not only looking at 45%, you're looking at 70%. And improvement activities is still just in a test. So you say, yes, I'm doing this, no, I'm not doing this. You have to have a 90-day documentation period, and it makes up 15% of your score. Going back to quality, so data completeness is very, very, very important. Again, it's a really high, it's a high-weighted category within your score itself. So data completeness, based on your measures that you supply, 60% or more of those measures have to meet all criteria for you to qualify for your full 3 points for that measure. If they don't meet that 60% or greater, now this is across all payers, this is your entire practice, this is not just Medicare beneficiaries that you're reporting these quality measures on. It's everybody within your practice. If you do not meet that 60% criteria, you'll be awarded 1 point. That's a really big deal when that whole score makes up 45% of your total. I'll have some other cool little notes here. Okay. So I know in the PEDS practice we do some PCMH stuff, some patient-centered medical homes. So in that category, that is directly related to the improvement activities. In order for you to be considered that, because there's a bonus for that under MIPS, but in order for you to qualify for that, 50% or more of your sites have to also be considered patient-centered medical homes. So if you have multiple sites and you have less than 50% that qualify for that category, then you don't get that bonus under this, under your improvement activity. Within promoting interoperability, one provider in a group can qualify, and then the whole group is allowed for their full credit for their promoting interoperability. Again, 2019, you have to be using, in order to get this at all, you have to be using 2015 certified technology. 2014 and before is no longer available. The cool thing about 2015 certified technology is that, for the nerds in here, it allows for more export. It removes the requirement that you have to use a vendor in order to extrapolate data from that practice management system. So you have a little bit more control in how you pull information and you can manipulate. And that is a requirement for the 2015. So if you can't get data, call me. We'll figure out how to do that. All right, so in order to not get a negative adjustment, I was trying to make sure I didn't do double negative there. In order to avoid a negative adjustment for 2019, you have to have at least 30 points within your whole entire score. So for quality, for cost, for promoting interoperability, and for improvement activities, total you have to have at minimum 30 points. Anything under 30 points, you will be receiving a negative adjustment. Nobody wants to get less money. So 30 points is a reasonable thing to achieve. If you have any questions about that, we can dive into further detail on how you can do that for your practice. Again, exceptional performance. There is $500 million sitting in a bucket somewhere for practices to be allocated that achieve that 75 points or greater. $500 million. I mean, it's a lot of money. So I think that that's It's a great incentive for people to want to, you know, do as best they can, try to get as high score as they can within that. So again, like I said before, 91.2% of providers that are active within the MIPS program are expected to get neutral or positive adjustment, again, diluting the ability for that minimum performance threshold in order for you to get a positive adjustment. The positive negative in 2021 paymaking year, 2019 performance year is 7%. We started at 4. That is gradually going up. The expectation is eventually it's going to be closer to like 16. What I will say to kind of touch on that 91.2 activity is that in 2017, for the 2019 payment year, the highest adjustment that anyone got. Now remember, it was transition year, it was brand new, people could choose to participate fully, get all sorts of data in, to really kind of exceed the bar. The highest adjustment that someone got for the 2019 payment year, does anybody know what it is? So 4% was max. So what was the actual max that somebody's getting this year? Anybody guess? 1.8. So it was a possible 4, but because there were so many participants that got neutral or better, the highest plus adjustment was 1.8%. So that just kind of goes to show you how important it is to participate and do best. So within the quality measures, of the total 460-ish that are out there, 26 were removed that were old. Most of those were removed because they were topped out. 8 general measures were added, 15 urgent care, and 13 incident. So of those quality measures, you know, there's a plethora. You can get the specialties, you can get general. I will say that claims-based reporting for the quality measures, a lot of those 26 that were removed were claims-based, typically because a lot of them was topped out, and there's just no room for any improvement there, so they removed them. So APMs is the advanced payment models under the macro umbrella. It's the second pathway other than MIPS. So these are just the specific changes. I won't go into a lot of them. I don't know if anybody here participates or is a member of an APM. But the Certified Electronic Health Records Technology threshold is 75% of eligible providers. So everybody under the APM, at minimum 75% of those eligible providers have to be using that 2015 certified technology. So they're exceeding the 8% revenue-based nominal amount standard through 2024. So that's your risk model there, kind of a shared risk model of the practice. So they're streamlining the measure definition criteria because a lot of the MIPS and APM criteria were kind of lined hand in hand. So the APM, because they take on a little bit more risk, they're trying to streamline exactly what those definitions are within those measures. They're clarifying the APM requirements, kind of hand in hand with the above line. And they're updating the MIPS APM measure set for the APM scoring standard. So the MIPS and the APM scoring is obviously different. They get an automatic 5% bonus for being an APM for kind of taking on that risk on the front end. And so they're kind of updating those measures that they're using. And I think there's a miss up there. Oh, virtual groups are still, I didn't put it up here, but virtual groups are still a possibility. You can't use it for 2019's participation year because you have to elect before 12/31 of the prior year if you want to participate as a virtual group. The definition of that is essentially eligible providers under the MIPS guidelines kind of gather together, single or smaller groups gather together and report their MIPS measures under one can for reimbursement. They can still stand alone as their own practice. They can bill as their own individual or their own practice. But as far as the NIT scoring, they can score together to kind of give them a better opportunity to really hit that 75 or plus points. Okay. I think that is all I have for this morning. Anybody have any questions?
We have a few minutes for questions. If anybody has questions you didn't get to ask earlier, now's the time. Thank you so much for coming this morning. Thank you to Jessica and Stacy. And we'll look forward to seeing you at our next Healthcare Helping. Thank you so much. And please remember to fill out your CPE and your rating. And if you have topics you want to see in the future, please let us know. Thank you.